Morning, everyone. Thank you so much for being here this early. Welcome to the Lions Lair. My name is Eric Tourville. That's the question we asked to our researchers over there. Enter the Lion Lair. Do you dare? Here's our special people this morning, our judges. I'm Eric Tourville from Quebec City. I work about 2.5 km from here. And I'll let everyone introduce themselves, where they're from. So maybe Cynthia Qian.
Good morning. You here?
Not yet.
Hi. Oh, now it's working. Hi, everyone. Thank you for all being here to see your bright and very excited faces. I'm very thrilled to be here. And I'm Dr. Cynthia Qian. I'm based in Montreal at the University of Montreal. This is my second year participating in this event. I'm just looking forward to hearing the contestants and Dr. Do's talk as well. And we'll show you a taste of the Canadian Lions Lair this morning.
I'm David. I'll just check this. Test. There we go. David Maberley from Ottawa. My first year as a Lion, and just looking forward to seeing the presentations.
Yeah, take that one. We know it works. Yeah, and I'm Geoff Williams from Calgary. Also very pleased to be here as part of the Supreme Court to hear these submissions. I'm very excited about the variety of things we're going to hear about this morning. So I'm sure everybody will be pleased.
Great. And okay, so it's one mic at a time. And Dr. Do doesn't need any presentations. She will have a talk later on. Unfortunately, we won't be here. We'll be deliberating outside, so she'll have to do twice. No, I'm just kidding. Now I'll have our researchers to quickly present themselves and where they're from. Maybe start with Dr. Mercer. He's the one we have first on our chart.
Hi, I'm Gareth. I'm a fellow at the University of Toronto in retinal surgery right now, and prior to that, I did my residency at McGill. Thank you very much for inviting me to be here and for coming at this early hour.
Hello, everyone. I'm Marko from the University of Toronto, one of the residents at U of T. Tremendously honored to be here as well and get the opportunity to present.
I'm Matthew Quinn. Don't hold it against me. I'm a neuro-ophthalmology fellow in Ottawa, and prior to that I was a resident in Kingston, and like my colleagues, very, very privileged and pleased to be here today.
That's to elevate the field that we brought some neuro-ophthalmology in. So I won't be reading all this, just as part of this process we have to give you full disclosure. So those are mine. Dr. Maberley, Dr. Qian, and I'll dwell a couple minutes on Dr. Williams. The other main disclosure for commercial support, this would not be possible without the financial support from Bayer. What we are actually giving are research grants, and this is through the Bayer program. We also report in-kind support from the Canadian Ophthalmological Society for mainly the logistical aspect. Danica, Lee, thank you so much for making this possible. All speakers have received honoraria from the COS as well. So those are your objectives. So when you finish and you go evaluate the program, you should be able to identify innovative Canadian retina research proposals and their intended benefits. And you should also, after Dr. Do's talk, describe how using emerging therapies can improve the care of patients. So here it is, first place for today's, so the best. We received a lot of candidates, a lot of proposals. We kept the 3 best. We start from scratch. Again, we'll evaluate everything this morning. If you have questions, so the first question, since it's the Lions that are be scoring those presentations, they'll have priority to ask questions. But again, there are a couple of mics in the audience. So if there's enough time to get 7 minutes to throw their pitches, and then we have 8 minutes to roast them afterwards. And then we'll debate who's going to get first prize, $35,000, second prize, $22,500, third place, $12,500. And all of you guys are going to be voting for the audience choice. Danica is going to take care of making this possible through whatever iPhones. I'm not even sure which modality we'll be using. So as we get here, it should be around 6:40. This is the schedule for the day. So we'll have the 3 pitches, and then the audience choice award. For that, we'll be outside of the room deliberating as you guys will be listening to Dr. Do's talk. And then I'll be back 5 minutes before 8 to give you the winner announcements for both the audience award and the big awards. So how will our researchers fare in the lines there? We'll have Dr. Mercer first on the podium through alphabetical order. That's how it's been decided. All yours.
Thank you for inviting me to present our pitch for a novel strategy for treating rhegmatogenous retinal detachment, which we have called minimally invasive suprachoroidal buckling. And I want to thank my supervisors, Peter Curtis and Ken Eng, for supporting this work. As you know, rhegmatogenous retinal detachment is a relatively rare condition, but it's also the most common reason for urgent ophthalmic surgery. And prior to the development of scleral buckling in the 1940s, it was uniformly a blinding condition. However, we now are fortunate to live in an era where we have multiple safe and effective techniques available to treat this condition, with single operation success rates at least as good as 80%. And so, for example, here I'm showing a case of a patient with a macula on superior retinal detachment with multiple breaks who had a fantastic outcome 3 weeks after a pneumatic retinopexy. And yet, there are some distinct disadvantages to our current techniques, particularly for patients with detachments caused by breaks in the inferior retina. And so here I'm showing another case of a patient quite similar to the first, with a macula on detachment and a progressive visual field defect for a couple of weeks. But in this case, you can see the detachment is caused by a break very inferiorly around 5:30, as highlighted by the green circle. So this patient is not typically a candidate for something like a pneumatic retinopexy. And so the question becomes, what's the ideal approach to treat this condition? And, some of you may consider a scleral buckle. Others might do a postplane of vitrectomy with long-acting gas or heavy silicone oil, or a combination of the two. But in any event, generally what we're considering subjecting the patient to here will be a fairly prolonged, sometimes painful recovery period with the presence of permanent orbital hardware, sometimes onerous positioning, and in most cases, a prolonged visual rehabilitation. So what we asked is, wouldn't it be incredible if we had a technique where with a single injection you would be able to treat patients with this kind of detachment and achieve successful retinal reattachment with a relatively comfortable eye, no positioning requirements, and a relatively rapid visual rehabilitation. And so this is where we hope to position this particular procedure, minimally invasive suprachoroidal buckling, which is a modification of this procedure, suprachoroidal buckling, which many of you may be familiar with. This technique is performed in the operating room, either in combination with vitrectomy or using chandelier endoillumination under the operating microscope. And the essence of the technique is to perform a small peritomy of the conjunctiva and then a scleral cut down to the level of the choroid, after which a blunt cannula, as shown here, or a lighted cannula is introduced into the suprachoroidal space. And a hyaluronic acid substance is injected underneath the break to create an internal buckling effect. And then once retinal reattachment is achieved, typically a laser retinopexy is performed. This technique has been demonstrated to be safe and effective in animal and human studies. However, it's not typically that frequently performed. And I think this is most likely because we're not in general that comfortable with this kind of invasive probing of the suprachoroidal space. And also because once we've already brought the patient to the operating room, I think most of us would be more comfortable going ahead with one of the procedures that we have more experience with. So what we're proposing is to take this procedure and convert it into something more like a pneumatic retinopexy, in the sense that it would be performed in the clinic under visualization using indirect ophthalmoscopy. And the critical change here is that the injection of the internal buccal would be performed using a specially designed microneedle, so would not need a scleral cut down. So the study that we're proposing has 3 steps involved. The first is for the design and fabrication of a custom microneedle. And this part of the study is being performed in collaboration with researchers at the Department of Engineering at the University of Toronto, shown here in the upper right. And what I'm showing you is a scanning electron micrograph of a commercially available spinal anesthesia needle of the Quincke type, basically to show you the variables that we'll be modifying to create our prototype needles. So the first you're very familiar with is the needle gauge. The second parameter is the primary bevel angle, which is shown here. And essentially this is going to be much more of an acute angle than is typically used in the standard hypodermic needles because of the small space we'll be working in. And then the third parameter we'll be varying is the presence or absence of the secondary bevel shown here. And it's this bevel that creates the cutting needle that is standard for hypodermic needles, or its absence would make more of an atraumatic needle. The length of the needle that we'll be using is based off of cadaveric studies of the thickness of human sclera between the pars plana and the equator, which is where we expect most breaks to occur, as well as the thickness of the overlying conjunctiva and tenons. Once we have fabricated a set of prototype needles, we intend to test these in preclinical studies using a previously developed whole donor eye surgical model. And the goal of this part of the study will be to identify the optimal needle for injection into the suprachoroidal space, and also to model the relationship between the volume of the injected hyaluronic acid and the size of the buccal that's produced. For the injectate, we'll be using Helon 5. And the success of the injection will be judged based on direct visualization of the buckling effect under the operating microscope, and we'll also be measuring the basal diameter and height of the buccal using B-scan ultrasonography. And I've shown at the bottom here, I won't run through it, the power calculation that we will need in order to identify a statistically significant difference between the needles. So once we've identified the optimal needle design, we will progress into early human clinical trials, basically to pilot the safety and efficacy of this technique. And this will be performed in human patients with macula off-retinal detachments with breaks confined to a single clock hour in the inferior 4 clock hours of the retina. So basically those patients who would not be amenable to a pneumatic retinopexy and who would thus require a surgical intervention in the operating room. And for the purposes of the safety trial, this will be performed in the operating room setting with access to monitored sedation in the event that it's necessary to convert to a pars plana vitrectomy. And we anticipate we would need to include about 5 patients for this study. So thank you very much for your attention. I look forward to hearing your questions and comments.
Dr. Mercer, on your microneedle design slide, you note the average scleral thickness in the anterior equatorial region of the eye is about 400 microns with about 25% variability. Assuming there will be a significant number of high myopes that might benefit from this procedure, given that's a population that often has small microbreaks inferiorly that ultimately need surgical intervention, how do you plan to manage that variability with your needle?
Thanks, Dr. Maberley. That's a good question. It's something we have thought about in a few different ways. So at the present time, we've been thinking about a fixed length microneedle. In future designs, it's possible we may consider something that's more adjustable by the surgeon at the time of injection, or at least with a few options available, as is the case with some of the commercially available microneedles right now. But as I said, the current design is a fixed length. And what we plan to do during the cadaveric eye studies is to try and include eyes with variable axial lengths to try and make sure that we represent those eyes with quite thin sclera to see, whether we are seeing evidence of penetrating too deep in the cadaveric studies. One of the other things that is part of how the injection will be done is that as the needle is being passed through the sclera, pressure will be applied on the plunger so that once it actually enters into the suprachoroidal space, the intention is that you feel a release of pressure as the viscoelastic begins to inject. And that's one way of being able to titrate, the depth that you're injecting. And that is what is presently done with the commercially available suprachoroidal injectors. And then another idea that we've been had recommended to us is to use, for example, anterior segment ultrasound or ultrasound biomicroscopy to measure the thickness of sclera preoperatively, and that way we could potentially decide which regions need to be avoided, for example, or which length of needle would be appropriate for a given patient.
Gareth, thank you for your excellent presentation. You really, in many ways, talked about two projects, and one was the development of the needle, and the other was the clinical part of doing the actual procedure in the OR, et cetera. But how much of this project do you see as being the needle development, and how much on the clinical side?
Thanks, Dr. Williams. So, in terms of my own involvement, I've seen the overall conception of the study and the study design have been my contribution thus far. In terms of the actual needle design, we're collaborating with a group of engineers at the University of Toronto, and I see them as having a much greater role to play in the actual design and manufacturing aspect with input from us based on our sort of clinical demand. So I think what I see as the study that I will be really conducting are the cadaveric studies, and then if we do finally get through that stage, then the clinical trial.
Dr. Mercer, that's a very interesting presentation, and I just wanted to follow up on the questions that were asked. As Dr. Williams said, this is a very ambitious project, and I'm just wondering, in terms of timeline, how do you foresee this going forward in terms of realistic deadlines and dates?
Yeah, also a good question, Dr. Qian. So I think it does depend a little bit how things unroll. We're at this stage where we have, our ethics process approved for the cadaveric eye studies, and we're in the process of doing needle design. That in itself has met with a few obstacles. So at the moment, it's a little hard to say how long that process will take, but I'm anticipating that within the next few months, we'll be able to begin the cadaver eye studies and hopefully finish that within 6 months, assuming that all goes according to plan. And then we would be beginning the clinical trial after that.
Great. And do you think that there are useful techniques that can be incorporated into the design of the needle using knowledge from the technology that's used in anterior segment surgeries, for example, in canaloplasties, or with the eye track device where you have a light that can indicate whether you're in the correct position or how deep you are? Do you think those would be applicable in this setting?
Certainly, the suprachoroidal buckling procedure that's done in the operating room does, in some cases, make use of a lighted catheter, and I do think that is a very useful technique. The way that I've conceived of the surgical procedure here doesn't involve actual direct visualization while the injection is happening, just to facilitate access to the space. So I think, we're going to see how realistic that is as we move forward. It may end up being that we'll have to alter the design of the needle and try and incorporate something like that, like perhaps build it into the end of a scleral depressor, for example, where you can visualize where you actually are. But I had hoped initially that the actual design of the needle could be as simple as possible to make this something that's not going to be, a very expensive device to be able to purchase. So that's how initially we're going to be moving forward.
Gareth, is there any reason why you wouldn't or couldn't use the commercially available needle that is being used for steroid injections, for instance?
Well, thanks. I had anticipated that someone would raise that question. Actually, we, at the very beginning of this study, had hoped that we would be able to make use of one of those needles, and we approached a couple of the companies that are currently manufacturing them. But at this point, they're not available commercially as standalone devices. And the response that we got from those companies was that they're looking to partner with drug developers rather than for a surgical application. So that's currently not accessible to us. But we're going to take that, that disappointing reality and turn it into something useful for us by making the needle more specifically designed for this application.
So, Gareth, I'm imagining I'm doing this procedure in my clinic. I'm looking forward to doing that someday. But my first thought is that very often when you're using a cryoprobe or something to do a procedure, and it's a little bit far back, and the conjunctiva, the fornix is in the way, would an angled design for the needle be considered as a way of delivering delivering into the suprachoroidal space the hyaluronic acid?
Yeah, thank you for that suggestion. That is something that I've also wondered about, knowing that the inferior fornix is going to be a pretty tough space to access. Again, at the moment, the needle design is relatively straightforward. It's just going to be a simple straight needle on the end of a syringe. But I think moving forward, we may have to consider other designs that are a bit more sophisticated, such as what you're describing, sort of built onto the end of a depressor. And there are some examples. For example, there's an external subretinal drainage device that is built onto a depressor and that can be deployed, I think, by Vortex Biomedical. So that's a design that we might be able to sort of adapt to this purpose. Thank you.
All right. Hello, everyone. I really want to thank the conference organizers for the opportunity to present today, and I want to thank my co-authors and collaborators for their support and help in preparing this presentation. So I'm Marko Popovic. I'm one of the PGY4 residents at the University of Toronto, and I'm really honored to deliver this presentation today. Before I get going, this is a listing of our relevant conflicts of interest for this presentation. So to begin, we know that proliferative vitreoretinopathy is a major sight-threatening complication of rhegmatogenous retinal detachment repair. It's actually the most common cause of surgical failure in rhegmatogenous retinal detachment repair. And we know that PVR involves a pro-inflammatory, pro-fibrotic, and pro-proliferative state. And although standard of care surgery, pars plana vitrectomy, with membrane peel, with or without relaxing retinotomy or retinectomy can be done, visual and anatomic outcomes still remain poor, and no standard of care adjuvant agent has emerged in this setting. Topotecan is a topoisomerase inhibitor that represents a promising treatment modality for this condition, and its indication currently is systemically as a chemotherapy agent for patients with metastatic ovarian cancer, but it also has been injected into the eye in patients with refractory or recurrent vitreous seeds from retinoblastoma. So far, the experience of topotecan has been promising when administered as an intravitreal injection, as it's been associated with no ocular or systemic complications. We believe that there's biologic plausibility for topotecan to inhibit PVR. In a primary culture and explant model of PVR, our collaborator, Dr. Leo Kim, and his team at the Massachusetts Eye and Ear found that the rate of proliferation of PVR membranes decreased by 50% after administration of intravitreal topotecan. Topotecan has also well-established safety when administered as an intravitreal injection. When we look at all of the studies looking at retinoblastoma, topotecan for retinoblastoma, we found no ocular or systemic complications that were observed with administration of this medication, as well as no differences in ERG amplitude after administration. We know that systemically, topotecan can be associated with various blood dyscrasias and interstitial lung disease, and for these reasons, we've taken these considerations seriously in designing our study protocol. So overall, there has been no clinical experience, no in-human trials of intravitreal topotecan for the management of proliferative vitreoretinopathy and retinal detachment, and this is why we're proposing the current prospective matched phase 1-2 cohort study investigating the efficacy and safety of this treatment in cases of PVR. To do this study, we'll include patients aged 18 and over who have rhegmatogenous retinal detachment with severe PVR. These will be patients who have failed standard of care surgery otherwise, and we'll be excluding any patient who does not have a rhegmatogenous detachment, and also patients who have proliferative diabetic retinopathy. We will be excluding all patients with primary RDs who come in with a retinal detachment at the first presentation. They will not be included in this trial. And also, given questions of teratogenicity of topotecan systemically, we'll be excluding all female patients less than 50 years old, and of course, patients with pre-existing bone marrow suppression, cytopenias, and interstitial lung disease. As part of this trial, any surgical technique will be considered, and this will be determined at the discretion of study investigators. And at baseline, we'll be collecting sociodemographics, clinical characteristics, and surgical characteristics as well. At our all follow-up time points, we'll be doing a comprehensive ocular exam, including visual acuity, intraocular pressure, and anterior and posterior segment examinations. Our clinical trial will have two arms, an experimental and a control arm. The experimental arm will be patients who are prospectively recruited who receive a series of 7 injections of intravitreal topotecan in addition to standard of care surgery. They will be compared to individuals in the control arm who are retrospectively recruited, and these will be historical controls who've received standard of care surgery without topotecan. And the interesting design feature of this trial is that we'll be matching 1-to-1 each patient in the experimental arm to a single patient in the control arm. And patients will be matched on 3 characteristics: age, sex, and the number of previous surgeries. When you look at our study schema, at baseline, we'll conduct a thorough screening process to ensure that patients meet our inclusion criteria and do not meet our exclusion criteria. And once patients are enrolled, they'll undergo a comprehensive ocular examination and undergo intravitreal topotecan within 1 week of having surgery for the first time. At the time of surgery, patients will undergo their second intravitreal topotecan injection, and then patients will have an injection at 2, 4, 8, 12, and 16 weeks for a total series of 7 injections over the course of the study. At each one of these visits, patients will be closely followed and monitored, and then our primary endpoint will happen at month 6, where patients will not have a topotecan injection, but will have an ocular exam performed. You may wonder what the rationale is for the dose of topotecan that we'll be using in this clinical trial, and what we've decided on is to use 8 micrograms per injection. And so we know on one hand that efficacy data supports the use of much smaller quantities of topotecan, which has been shown to be efficacious for this condition. At the same time, the safety of this 8 microgram dose has been also demonstrated. When we look at the retinoblastoma literature, doses anywhere from 8 to 30 micrograms have been associated with no adverse events. And our injection series and our protocol is based on the phase 3 randomized GUARD trial, which looked at intravitreal methotrexate for PVR as well. And we know that methotrexate and topotecan have a similar half-life, and so we're modeling our series of injections based on what the GUARD trial has reported. Our primary outcome will be the risk of retinal detachment secondary to PVR specifically, and our secondary outcomes will include visual acuity, as well as secondary anatomic endpoints and complications. We'll be conducting a statistical analysis including a univariable, conditional, logistic, and linear regression model. To power the study adequately, we'll recruit 25 participants in each of the experimental and control cohorts. And then at the halfway point of this trial, we intend to do an interim analysis. And so to analyze all of the cases to date and to look and see what the difference in efficacy is in terms of the primary endpoint between the experimental and control cohorts. If there's less than a 10% difference, what we'll do is we'll administer topotecan at a slightly higher dose of 12 micrograms as opposed to 8 micrograms to see whether this higher dose is associated with significant efficacy. I can confirm that we've received a no objection letter from Health Canada to begin this trial, and we've also received Research Ethics Board approval from both Sunnybrook Hospital and Unity Health Toronto. So in conclusion, this study represents the first in-human trial for intravitreal topotecan in the management of PVR. This is truly an opportunity for novel treatment discovery and evaluation for a condition that remains a blinding condition today. And it's truly an opportunity for us as Canadian ophthalmologists to play a leadership role in this setting. Ultimately, the trial is designed to uphold patient safety as its main priority, and we will not waver from this promise. I want to thank you all very much for your time and attention. Thank you.
If I may start. Thank you. That was a great presentation and a novel education for me on this particular drug as well. And having had some experience in some PVR-related trials, the first question is the surgeon going to be blinded to the initial injection prior to that surgical procedure? Are they going to be aware that they got the drug or not?
That's a great question. Because this is the first in-human experience, we're not going to be blinding at this phase. Basically, the study investigators, there are 3 study investigators, they'll be the ones who will do the surgery and also administer the medication. As I alluded to, the topotecan patients will be recruited prospectively, whereas the control patients will actually have already had surgery, and so they'll be retrospectively recruited. And so surgeons will know that the patient has received topotecan.
So just to follow up on Jeff's question there, in the history of our field, there has never been a positive RCT showing significant benefit to any adjunct in the randomized clinical trial setting, whether it's the 5-FUs or mitomycins or other sort of, heparin, all the variety of things that have been tried. And the reason typically is there's so much noise in surgical trials of PVR based on surgical technique, amount, and probably molecular components of the membranes themselves that we truly don't understand. How do you see a cohort study design and not a randomized clinical trial giving you the opportunity to actually show a clinical difference?
Yeah, that's an excellent question. And, we've debated this at the study investigator level and with Health Canada of how do we design the study appropriately to, first of all, see what the efficacy signal is, but also make sure that we're upholding patient safety. And, in this specific trial, this is the first time ever we're going to be using this medication for PVR. And so we're really trying to see, is there any efficacy signal at all? We're trying to minimize confounding by matching patients. And, that was carefully thought out, because if you randomize them at this stage, when you're recruiting such a low sample size, there is a high risk that there are going to be baseline imbalances between groups with randomization with such a small sample size. And so matching was what we preferred at this stage. And then we'll see. I mean, we've built in an interim analysis as well to see perhaps there may be a dose-dependent relationship that, Dr. Kim believes that there is. And so if there's, a kind of mild efficacy signal to begin with, at the halfway point, if we find that difference is less than 10%, we'll increase the dose of topotecan to see whether there's an efficacy signal at all, even with a higher dose. And so overall, all of these methodological points that we've done to build it into the study design are meant to see if there's an efficacy signal there, it's going to come out. I understand that there's going to be some noise. I understand that our trial is not perfect, but this is really the first in-human experience with the medication, and we need to do our best to evaluate it at this time.
So did I miss it, or have there been animal PVR study models studied with this drug?
So Dr. Kim's lab has looked at human models of human cultured explant models of PVR, and they have administered topotecan, as I said, in doses much less than what we've considered, and they found very high efficacy. So, more than 50% reduction in proliferation. And when you look at the lengths of the membranes themselves, an almost 5-fold reduction in the lengths of the membranes found in the preclinical work that he's done.
But you're still going straight to humans prior to any animal studies, for example. We've submitted all of the data that's available to us right now from Dr. Kim's work to Health Canada, and we've been in many discussions with them around whether it's this is the reasonable next step, and we've confirmed from them that we've received a no objection letter stating that they are okay with us proceeding with this trial in its current form.
Marko, I'm just curious how this study came to be here in Toronto, or here in Canada, and having recruitment in Toronto. I mean, I train at Mass Eye, so I know that's a big anti-PVR center. They're really interested in looking at agents. I mean, the GUARD trial, that's where it started, the one that you were referring to. So has this been looked at in the States, or is Toronto going to be the first recruitment site? And how did that collaboration happen?
Yeah, for sure. So another excellent question. So, the collaboration really happened. My supervisor, Dr. Rajiv Mooney, knows Dr. Kim well, and we wanted to do some work with him. We knew that he was an expert in PVR, and so we wanted to look at something involving PVR, and he's the one that connected me to Dr. Kim, and Dr. Kim suggested the idea of doing this trial, and then I really took it from there, designed the protocol, designed all of the methodological points, submitted it to Health Canada and REBs, and in the end, Dr. Kim was happy to collaborate with us. Unfortunately, on his end, he wants to look at this as well, but he's had some issues surrounding, very stringent regulatory requirements in the States, and has not been able to get the trial off the ground there. And so we're actually in a position now where we can really play a leadership role here in Canada, looking at this medication for the first time, given the collaboration we have with Dr. Kim.
Thank you. That's very clear. And can you also just go through the design, the rationale for the protocol? Because you were saying the dosages and the timing were based on GARD. GARD obviously starts off often on weekly basis, then goes to Q2 weeks. And here you have 7 injections that already start at Q2 weeks. So can you explain that?
Yeah, so there are some modifications. First of all, we know from the GARD trial, they've just looked at the analysis of their results. And what was borne out is that in their initial sample size, they were actually not able to find a difference between methotrexate and control cohort. It was really only when they pooled data from other publications that had historical controls and brought all that data together that they actually had a significant p-value for their trial. And so, the efficacy signal, unfortunately, there was not great. And so the question is, how in this trial can we, if there's a true efficacy signal here, how can we ensure that that is being well represented? And so the additions that we've done on top of GARD is that we've designed a schedule where we'll start actually before surgery, because PVR happens even before surgery is done. And so we'll have the first injection before surgery, we'll do the second injection at the time of surgery, and then we'll closely do injections in the first few intervening weeks, bi-weekly, as you mentioned, consistent with the GARD trial, and then extend it from there. Again, this is, as I said, this is a first in human experience, and so we don't have all the facts available to us. But based on all of the evidence that's available on the ground right now, we think this is a reasonable treatment protocol that if there's actual true efficacy there, will show that in this trial.
And patients typically redetach 6 to 8 weeks from PVR. I've rarely seen that happen 4, 5, 6 months out. So why do you guys go that far out?
So, yeah, this was also debated extensively. And this was just really designed to, in those rare cases that there are late redetachments from PVR, that we're able to capture those and ensure that, again, we don't know what the solution is going to be, but perhaps if topotecan is administered only at the beginning and not for 2, 3, 4 months out, perhaps that might also compromise the efficacy. And so we're following to 6 months. We want to see at a longer time point whether there's robust reattachment, and the data will show us whether how many are late.
I think the follow up at 6 months. It was just the injection at 4 months. It's a little out from, and no worries about injecting retina that's detached and high with a detached retina before the treatment. Why don't we leave it there when we finish? Could we?
So yeah, just like in the case of pneumatic retinopexy, where an intravitreal injection is done, it would be the same procedure. The study investigators are all very experienced at intravitreal injection, so I don't foresee a complication with that.
Awesome. Thank you so much. Out of time.
Thank you very much.
So last but least, Dr. Quinn. So dysbiotic events and the risk of neovascular age-related macular degeneration, a population-based study.
All right, well, thank you, and good morning, everyone, and thank you to my colleagues who presented before me. As this audience will likely all be familiar, AMD is a significant health policy issue. This is a leading cause of irreversible vision loss, especially among older adults in developed nations, such as Canada, where more than 2.5 million individuals live with AMD. And as the clinicians in the audience will recognize, a major challenge with how we manage AMD at present is that virtually all of our treatments are targeted towards neovascular or wet AMD. And although efficacious, these treatments are associated with a high cost at the system level and a high burden of treatment at the patient level. The bottom line is innovations are called for in how we manage AMD, especially at the transition to neovascular disease. Aberrant immune activation and excessive inflammation have been implicated in the pathogenesis of AMD, and this in particular has been emphasized at that transition to wet AMD, where we know there are inflammatory changes that can be detected not only at the tissue level in the retina, but also systemically. And for that reason, it has been speculated that a systemic trigger could precipitate progression of AMD. Nevertheless, the identity of such a systemic immunologic trigger remains obscure. The microbiome refers to the genomes of the trillions of microorganisms that are normally found throughout the human body, predominantly the gastrointestinal tract. And a full discussion of the role that the microbiome plays in mediating disease is, of course, beyond a 7-minute talk, but suffice it to say there are extensive interactions between the microbiome and its constituents at the tissue level and systemic immune responses. And you may not then be surprised to hear that shifts or changes in the microbiome have been linked with immune-mediated disease throughout the body, uveitis, asthma, type 1 diabetes, multiple sclerosis, the list goes on. Dysbiosis refers to compositional and functional shifts in the microbiome, and this can be detected experimentally after clinical exposures, including infections, which in virtually any organ system can produce dysbiosis, as well as exposure to medications, in particular antibiotics, so there is a long list there as well. And when there is a shift from a healthy, if you will, healthy microbiome to a dysbiotic microbiome, that is when we see this increased risk of immune-mediated disease. So now that you're all excited, this is the question, right? Is dysbiosis associated with AMD? Surely, if I'm up here talking about this, then maybe there's a link. And you're on the right track. In recent years, there have been a number of publications, including one from our own group in the bottom right here, interrogating changes that can be detected in the microbiome in patients who have newly been diagnosed with wet AMD. And looking at different tissue sites, the pharynx, the intestine, the nose, the mouth, and collectively this body of literature would indicate that dysbiosis throughout the body, particularly the gastrointestinal tract, is associated with progression to wet AMD. So this is pretty neat. This means that what's happening in your gut may have something to do with what's happening in your eyes. But where does that dysbiosis come from? The study question that we're proposing to answer are clinical exposures that produce dysbiosis, in particular infections and medications, associated with the risk of progression to wet AMD. What we're proposing is a population-based case control study for the province of Ontario, where we will compare cases with new wet AMD to controls on the basis of a different, or whether or not they've been exposed to a dysbiotic event recently. The data for the proposed study come from population-level databases for the province of Ontario. These are housed at a nonprofit research institute called ICES. A few of the key databases are shown on the left and the right of the screen in blue. These databases are linked at the patient level and allow us to extract data on patient demographics, insured physician services, including intravitreal injections, provincially funded medications, including anti-VEGF agents, as well as details related to hospital visits. The base cohort will comprise of all residents of Ontario, 66 and above, with at least one visit to an optometrist or an ophthalmologist in the preceding year, without any recent intravitreal injection. Analytically speaking, the study outcome is new wet AMD. We know that wet AMD typically presents fairly soon after disease onset. Treatment is generally indicated in a prompt fashion. So our surrogate for that outcome is a first intravitreal injection with an anti-VEGF agent, which specifically was dispensed for AMD. The cases then are all patients in the base cohort experiencing the outcome. They are assigned an index date, which is the date of their injection, and up to 5 controls for each case are matched on age, sex, and the presence of diabetes. They are assigned the same index date as the matched the matched case. In our study, the exposures of interest, or dysbiotic events, 2 major categories, infections and medications, both of which are known to powerfully perturb the microbiome. Infections we will analyze by organ system, organism, and severity, where those data are available from the databases we're using, as there's evidence that all of those factors can influence the resulting dysbiosis. Medications in particular, we're looking at antibiotics, but other antimicrobials and other medications will be considered as well. In this case control study, we'll use matched or conditional logistic regression to estimate a strength of association between the outcome, new wet AMD, and exposures occurring within, at least in a primary analysis, 3 months of that index date, while controlling for the covariates at the right of the screen. And in a preliminary power calculation, we estimate nearly 28,000 cases will be eligible for inclusion. And for an exposure occurring in 1% of controls, that would give us power to detect a statistically significant odds ratio of 1.18, which we feel is more than adequate for an impactful study. So why does this matter? I think this is probably the most important slide. Identifying dysbiotic exposures that may trigger AMD progression. What is this going to do for us as the medical community, in particular in the management of AMD? First and foremost, this may inform development of novel treatments. In other immune-mediated disease, we know that the microbiome can be targeted and re-engineered deliberately. This can be done with microbial transplants, certain medications, dietary interventions, and so on. If we're able to demonstrate some signal that dysbiotic events can increase your risk of AMD progression, perhaps further research is warranted into these types of strategies in AMD. The second area, perhaps one that might be actionable on a sooner basis, would be guiding healthcare decision-making in at-risk individuals. We can imagine modifying our screening follow-up time for our AMD patients on the basis of how likely it's been that they were exposed to a high-risk exposure, if you will. Or, for example, counseling our patients with early or moderate dry AMD to avoid taking a certain antibiotic because of the known risk of progression to wet AMD. And with that, I'll thank you for your attention. We're pretty excited about the project, and again, feeling very privileged to be up here and hopefully was able to share some of that excitement with you.
I'm always going first. Sorry. A terrific idea, and I really think that you may well be onto something. And I've sort of got two sort of questions / points. One is that I've often wondered in seeing a lot of patients that are on chronic anti-inflammatories that they are somehow protected, and I'm wondering if that you could include in your study patients who are on chronic anti-inflammatories for some reason as being possibly a protective mechanism in this study cohort that you're looking at, which is obviously huge. And my second question then would be, okay, let's say you find a positive connection. What do you do about that? So
yeah,
what do you propose, or what do you foresee as being your therapeutic reaction to that?
Yeah, these are great questions. We're really getting to the meat of it. I've presented this hypothesis as we're going to see factors that may increase your risk of disease. It's quite possible that there are factors which will be protective. And certainly the research methodology could be generalized to include other exposures, which may, whether it's by the microbiome or other mechanisms, may mediate some change in your AMD risk. So I think it's a fantastic idea to consider other agents. The nice thing about this type of study is that at least, so this is an Ontario-based study, all medications dispensed to individuals 65 and above are covered under, well, most of them are covered under the Ontario Drug Benefit Program. And so we have access, we can look at what they've been dispensed, the dose, how often. So we have this very granular data on drug dispensal. The second, can you just kind of briefly summarize the second question as well?
Yeah, you found the connection.
Yes, what do we do?
Now what?
Yeah, this is a fantastic point. And I'll concede a limitation of this study, although this is a dangerous thing for me to do, should we find a positive effect? That certainly doesn't implicate the microbiome, right? We're kind of indirectly testing this hypothesis. There are other potential explanations, of course. And this is a first step. If we find some signal that, agent X or infection Y increases your risk, then that's rationale for the next set of studies, which in fairness probably wouldn't be as amenable to a population-based methodology. Then it's back to the bench, or the lab, so to speak. Why would a certain medication increase your risk or decrease your risk of disease progression? So this is going to be about generating a hypothesis for a next set of experiments.
Thanks for a great talk, Dr. Quinn. Quick question around your very short pre-assessment interval of 3 months, when we know that many of the factors that could be triggering this could be years prior.
Yeah.
AMD does not occur typically in the 3 months preceding the onset of new pathology. Why not look back with the ISIS database 5-10 years?
Yeah. A great question again. I think I was mindful, kind of in anticipation of what questions I might be asked, that some might criticize the 3 months for being too short. And I think it certainly could be too long. And the nice thing about this type of study, I'll lead by saying, is that we can adjust this. And it's pretty, I don't want to say trivial, but straightforward once we've operationalized our analysis to go and say, okay, instead of 3 months, let's try 12 months or 2 weeks for that matter. I think the choice of 3 months it's an empiric choice based on our thinking, well, if you have some event, how long does it take to reprogram your microbiome? How long does that take to translate into some end organ effector change? You see NVM develops, patient becomes symptomatic, they seek treatment, they're treated. There's some sort of time that elapses there, which is at least on the order of several weeks. In terms of longer term exposures, absolutely. Exposures, we know children who are exposed to antibiotics have an increased lifelong risk of developing asthma, and that is felt to be related to shifts in the microbiome. At some point, we need to say, what's realistic as far as a ascertainment window. And if you look too far back, then there's a risk of introducing other confounding variables as well. And from a practical point of view, we're looking at patients. I mentioned our drug coverage data starts at age 65. If we want to look back, let's say 10 years, then that means that all of our patients have to be at least 75 and above. So we start kind of attenuating our cohort with a longer ascertainment window. So 66 we felt was reasonable. This way, if we want to go back up to a year, we can. But there will be a little bit of playing around with the ascertainment window for sure.
This is a very exciting field, and I think it's a field that is receiving a lot of attention. There are other studies that are now associating microbiome with AMD. We know big researchers at the Shea Institute. There's even a microbiome lab that's set up by Dr. Skondra in Chicago.
Yep.
So what does your study bring that's novel? Is it your expertise in the field? Is it the Ontario or Ottawa population? Can you elaborate?
Yeah, thank you. And we're very mindful of our colleagues, and many of whom are collaborators, or we'd like to have collaborators among them in other institutions, and recognizing that science is a team sport and we all kind of have our piece to play. I think the real strength here is the membership of the team. Dr. Rouleau, who you'll see here, is one of the co-PIs on the project, is an ophthalmologist, clinician scientist who practices or runs a lab with an interest in basically immune mechanisms of ocular disease. Rob Campbell, the other co-PI, is an expert in population level health research. I have an interest in that field as well. We have PhD statisticians on the team. We have retinologists. So the team makeup, I think, lends itself to using kind of a novel approach, which is looking at population level data, which has not been looked at in terms of testing this hypothesis. A lot of the work that's been done is small cohorts of a few dozen patients, laboratory science, which absolutely has a role and indeed has provided the hypothesis which we're testing here. But this is our first opportunity to take a step back, leverage the expertise of the team, and ask this question kind of from a bird's eye view, for a province with a population of more than 14 million people.
Are you also interested in the genetic contributors to AMD, or is there a way to incorporate that into analysis?
Oh yeah, that would be great. The main limitation with this type of study, not that there's too many limitations, I promise you, but we only have the data that are available in databases. And unfortunately, we don't have things, I hate to say it, but visual acuity or, the OCT, we just don't have this in a database fashion. And that would include, various genetic markers, which undoubtedly are at play here. They're central to this, but we don't have access to them. But again, going back to my earlier comment that, this is going to be a launching point for subsequent hypothesis testing. And I think that's where, perhaps another set of experiments might follow. Thank you.
Questions from the audience?
Some of this data has already been looked at in the Blue Mountains Eye study. Have you looked at that and where they're up to this type of area of the study?
Yeah.
They have got a very controlled population. They've got all this data and have been looking.
Yeah. So to my knowledge, a lot of.
Repeat the question.
Yeah, the question was, looking at other population cohort studies like the Blue Mountains Eye study, and if I can kind of paraphrase, kind of what is our study adding in addition to that, and kind of what are the gaps that are being filled. I think the way that the study is being framed as far as testing this hypothesis about dysbiosis is a bit unique. Other studies have certainly looked at exposures that certainly are likely dysbiotic in nature, but they haven't tested this hypothesis specifically. I'll have to, certainly reference those studies specifically and make sure that, the exposures that we're testing are complementary to those. But to my knowledge, a population-based study specifically looking at events which are known to be dysbiotic remains lacking in the literature to date. Okay.
Thank you so much,
Thank you, everyone.
Dr. Quinn. So from what I remember, it's time for us to leave. And I believe Danica is coming up. Yeah.
Thank you so much, Dr. Tourville, and to our panelists and to our Lions. I'm not sure we can hear. I'm a little shorter than they are. So it's now time for the Audience Choice Award. While the judges are deliberating, we will be doing the Audience Choice Award. So if you could please take out your phones and scan the QR code, it will bring up Slido and it will give you the opportunity to make your vote. And remember, this is an extra $5,000 to one of our finalists. And thank you everyone for joining us this morning. For those of you who don't know me, my name is Danica Nukup and I am the CPD manager here at COS. Okay, I think I see all phones down. So these are our three options. So pitch 1 by Dr. Gareth Mercer, pitch 2 by Dr. Marko Popovic, and pitch 3 by Dr. Matthew Quinn. While you are voting and while the votes are being tallied, I am going to introduce our keynote speaker for this morning. So Dr. Diano Do. Dr. Diano Do, MD, is Vice Chair of Clinical Affairs and Professor of Ophthalmology at the Byers Eye Institute at the Stanford University School of Medicine. She is a leading surgeon scientist who has over 15 years of experience in clinical trials and retinal research. She has an active clinical practice and specializes in the surgical and medical treatment of retinal disorders. She has been the principal investigator and co-investigator on more than 35 clinical trials investigating novel treatments for retinal diseases such as neovascular age-related macular degeneration, diabetic macular edema, diabetic retinopathy, and retinal vein occlusion. She's authored over 125 publications in the medical literature and has contributed to over 25 book chapters. I'll now welcome Dr. Diano Do to the stage.
It's a pleasure to join all my Canadian friends this morning and to provide an update on clinical innovations from bench to bedside. The future is now. My disclosures are noted here. Let's first talk about neovascular age-related macular degeneration, a common condition that all of you encounter every day in your clinical practice. And specifically, we're going to address the unmet need that we see today in our clinical practice. We know from multiple published studies that real-world analysis of clinical databases shows that our patients actually have not achieved outstanding visual outcomes compared to those enrolled in clinical trials. Certainly, there remains an unmet need for durable VEGF inhibitors because one of the culprits to suboptimal visual acuity outcomes is the infrequency of injections given in real-world practices. When scientists looked at this unmet need, they investigated whether increasing the molar dose of aflibercept, an FDA-approved medicine, would provide a clinical benefit. And in preclinical studies, they looked at increasing the molar dose by 4 times the amount in rabbit eyes, actually extended the duration of VEGF inhibition by over 3 times the natural duration. Therefore, a high dose of aflibercept, 8 milligrams compared to the standard 2 milligram dose, was developed for human clinical use. And that's delivered in 70 microliter volume and is a novel formulation developed for the human eye. This high dose of aflibercept was then tested in phase 3 clinical trials. I'm going to be discussing the PULSAR clinical trial of high-dose aflibercept in eyes with treatment-naive neovascular AMD. In this randomized clinical trial, there were 3 different dosing regimens. 8 milligrams of aflibercept given every 12 weeks after 3 loading doses, or 8 milligrams of aflibercept given every 16 weeks after 3 loading doses. And the comparator arm was the standard 2 milligrams of aflibercept given every 8 weeks. The primary endpoint of this study was mean change in visual acuity, and it was designed as a non-inferiority clinical trial. Let's first look at the dosing regimen. Eyes that were randomized to 3 loading doses of 8 milligrams of aflibercept were then evaluated at certain pre-specified intervals for dose regimen modifications. And what were these criteria? If patients had a 5-letter or greater visual acuity loss, or an increase in their OCT retinal thickness of 25 microns or greater, these patients were then adjusted to either shortening their interval or they could be extended. The minimum dosing frequency was every 8 weeks for aflibercept. The key inclusion and exclusion criteria are very similar to other phase 3 clinical trials of neovascular AMD. And patients in this study had to have active neovascular AMD detected on OCT or fluorescein angiography. When we look at the baseline characteristics among the different treatment arms, we can see that they were fairly well balanced, and the lesion size were about 6.5 millimeters squared. Now let's look at the primary endpoint. We can see that the primary endpoint was met in both 8 milligram dosing arms of aflibercept, and both of these were non-inferior to the standard 2 milligram aflibercept dosing group. If we take a little bit closer look at the high-dose aflibercept treatment arms, we can see that 79% of patients were able to be dosed to the 8 milligrams given every 12 weeks. Furthermore, 77% of randomized patients were able to be dosed to the 8 milligrams every 16-week dosing arm of aflibercept. And when we look at the totality of the subjects, we can see 83% of eyes randomized to high-dose aflibercept were able to be dosed every 12 weeks or beyond and still meet the primary endpoint of the study. If we take a closer look at the high-dose aflibercept group, we ask ourselves how many patients were able to be maintained on these dosing intervals throughout the first year of the study. And we can see first on the left-hand side of the screen that if you were randomized and put in the 8 milligrams every 12-week dosing arm, you were able to stay in this. 79% of these patients stayed in that dosing regimen interval throughout the first year of the study. Furthermore, if you were able to be randomized to the 8 milligrams every 16 weeks of aflibercept, 77% of these eyes were able to maintain that dosing interval throughout the first year of the study. How does this translate to the number of injections? Well, we can see that if you're randomized to 8 milligrams every 16 weeks, on average, you only required 5 injections to maintain these visual acuity outcomes through the first year. If you were randomized to the 8 milligrams every 12 weeks, patients only required 6 injections the first year. And these numbers are quite impressive because when we look at these real-world studies, on average, many patients in our clinical practice receive only 5 to 6 injections of VEGF inhibitors during the first year of treatment. What about fluid? We use OCT as a marker of disease activity in our clinical practice. And when we look at the proportion of patients without retinal fluid in the central subfield at weeks 16 and 48, we can see that high dose of aflibercept provides great disease control, eliminating fluid in that central subfield, which is so important to their central visual acuity. We can look at fluid marker in another way, looking at the time to a fluid-free central subfield. And we can see that there is an advantage with high-dose aflibercept in that the time for fluid extraction from the central subfield is quicker and more rapid with 8 milligrams of aflibercept compared to 2 milligrams of aflibercept. What was the effect of treatment on central retinal thickness? This looks at the OCT reductions in retinal thickness over the first year, and we can see with administration of both 8 milligrams and 2 milligrams of aflibercept, there's rapid and robust reductions in retinal thickness, which are sustained throughout the period of treatment. Now let's look at safety. We know safety is utmost paramount to our patients, and we can see that most frequent adverse events were very mild and typical of intravitreal injections, such as subconjunctival hemorrhage or eye irritations. More specifically, if we look at intraocular pressure, because this novel formulation of 8 milligrams of aflibercept is 70 microliters, so 20 microliters greater than the standard 50 microliter dose we're used to, we can see there were no safety signals related to elevated intraocular pressure. In terms of intraocular inflammation, there also were no safety signals associated with a higher dose of aflibercept, and the overall rate of intraocular inflammation in 8 milligrams of aflibercept was similar to that seen in 2 milligram dose. If we look at systemic safety, again, there were no safety issues. So in summary, when we look at the PULSAR study of 8 milligrams of aflibercept dosed every 12 weeks or every 16 weeks, we can see that the study met its primary endpoint in that both 8 milligram doses were non-inferior to the current gold standard of 2 milligrams of aflibercept. And more importantly, we can see that the results showed that patients could be dosed less frequently with the 8 milligram dose of aflibercept. 79% of eyes could be dosed 12 weeks, 77% could be dosed every 16 weeks, and in total, 83% of eyes could be dosed 12 weeks or beyond. Furthermore, there were no safety signals with high dose of aflibercept, so this is a promising new agent that likely will be FDA approved in the United States this summer and hopefully in Canada in several months following. It'll be an exciting new drug to add into our armamentarium for wet AMD. Now let's transition to another unmet need, which is the advanced atrophic form of macular degeneration, geographic atrophy. Many of us know that we encounter these patients in our clinical practice where they have these large subfoveal lesions, which obviously progress over time and lead to more large scotomas and loss of central vision. What can we do for these patients? Well, previously there has been no approved therapy, but over the past few months, there has been a new treatment approved in the United States, which is pegcetacoplan, a complement inhibitor that's delivered via an intravitreal injection. Pegcetacoplan binds to C3 and C3b, inhibiting the downstream effects of the complement pathway. In prior studies, the complement pathway was implicated in the pathogenesis of advanced AMD. Because of this, phase 3 clinical trials, the OAKS and DERBY studies, were conducted globally to investigate whether intravitreal inhibition of a C3 inhibitor could slow down the progression of the atrophic geographic atrophy lesion. Patients in these studies were randomized either to sham injections or pegcetacoplan given every month or every other month, and patients were followed for over a 2-year period. The key inclusion and exclusion criteria in this study showed that CNV in the fellow eye was not exclusionary in the study. So patients who had a history of CNV in the fellow eye could still be enrolled in this clinical trial. When we look at the key demographic and baseline characteristics in the study eye, we can see that patients in this study could have both subfoveal geographic atrophy or extrafoveal geographic atrophy, and they could be enrolled. And what we're looking for in this study is the growth of the atrophic lesion. And we look at lesion growth, we have to remind ourselves that non-subfoveal lesions tend to grow more quickly than subfoveal lesions, and this is based on natural history studies. Let's look at some of the clinical results from these clinical trials. We can see that in both the OAKS and DERBY studies, at month 12, there seems to be a reduction in the growth of geographic lesions when given the C3 inhibitor. Of course, these reductions in growth are quite small, 21% in the monthly group, 16% in the every other month group in the OAKS study, 12% in the monthly group, and 11% in the every other month dosing group. So these are not large reductions in geographic atrophy lesion growth, but quite smaller effects. What happens over time? If we follow the patients for over 2 years, we can see that the clinical effect may have increased over time, with lesion growth reductions of 18 to 22% in the OAKS study and 18 to 19% in the DERBY clinical trials. Based on this 24-month data, the US FDA approved the use of pegcetacoplan for geographic atrophy. When we look at the linear slope analysis over 24 months, we could also see that the benefit of treatment increased over time. And there was a slightly higher benefit to monthly administration compared to every other month administration. What happens to lesions that are extrafoveal compared to subfoveal? We can see that both types of lesions benefited with complement inhibition, and that those patients who have both extrafoveal and subfoveal lesions could possibly benefit from this treatment. Is there any effect on visual acuity? Well, it was very difficult to determine an effect on visual acuity, especially in those eyes who already had foveal involvement. And in this particular patient population, we did not see any visual acuity benefit effect. And I think generally in most of these geographic atrophy studies, visual acuity is not a very good marker for disease progression, since many of these eyes already have foveal involvement. If we looked at a post hoc analysis looking at microperimetry, which is another way to evaluate visual function, there appeared to be a slight benefit with complement inhibition when we looked at the junctional zone in these eyes. The junctional zone is that area at the border of the geographic atrophy lesion where there still is healthy retina. And microperimetry did detect that there was a slight benefit to complement inhibition. The microperimetry junctional zone analysis showed that the signal of functional preservation was still present when given the complement inhibitor compared to the sham treatment arm. What about safety? Complement inhibition was relatively safe. There were no big safety signals. The only safety signal that was of concern was intraocular inflammation. There was a small rate of intraocular inflammation. And if we look back at ischemic optic neuropathy, actually, there was a slightly higher risk of non-arteritic ischemic optic neuropathy in those eyes that received pegcetacoplan. When we looked more closely at those cases, it appeared that those patients at baseline had a disc at risk with a small cup to disc ratio, and the temporal sequence of developing the ischemic optic neuropathy did not appear to be associated with the actual administration of the injection. More recently, analysis was done looking at the conversion to exudative age-related macular degeneration in these eyes, and there was a slightly higher rate of developing wet AMD in those eyes given the complement inhibitor. So that is something that we must inform our patients with. Many of these exudative lesions were of the occult type and that were small and located at the edges of the geographic atrophy lesion. So in summary, the three big adverse events associated with complement inhibitors were the conversion to exudative AMD, the slightly higher risk of ischemic optic neuropathy, and a very low rate of intraocular inflammation. So in summary, there's been very exciting development in the field of geographic atrophy, and more recently, the FDA approval of pegcetacoplan, which is the first approved treatment for geographic atrophy In the near future, we likely will have a second new drug that's also a complement inhibitor. It inhibits C5 that will likely be approved by the FDA, and something that many clinicians and retina specialists in Canada will have access to in the near future. Thank you again for allowing me to share this information with you. I'd be happy to answer any questions that you may have. I guess a question for many of you audience members. How many of you are currently using any novel agents such as faricimab for the treatment of wet AMD? That was approved in the United States, and I think it's also approved in Canada right now. Does anyone here have experience with that? A few of you. Can you share if you've noticed any increased durability or any effects with these new agent on the market?
I mean, rolocizumab first, certainly, absolutely. I don't think anything dry is as effective as that. I haven't had much chance at the higher dose yet, so I'll say some of the available ones. But of course, there's some information. So then we look at faricimab, and yes, but I mean, it's very early, and we're selecting cases that we're supposed to treat with other agents, and so we're very happy with some of the switch data. Treatment naive experience has been somewhat limited.
Yes. So as many of you know, faricimab is another approved agent that inhibits both VEGF-A and angiopoietin-2. So that's something exciting that we'll have in our armamentarium, as well as the high dose of aflibercept. Great. Well, I see that our Lions are back in the room right there in the back, and hopefully they'll be able to announce the new exciting winner. Thank you again for allowing me to share this information with you.
So without further ado, and since my short-term memory is getting worse and worse with years, the award from the audience goes to Dr. Quinn. Very good. So again, here are our candidates. Winners are for third place. I'm not sure if the amounts, but it was $12,500 from the Bayer sponsorship goes to Dr. Popovic. Second prize for $22,500. Again, as research funding from Bayer goes to Dr. Quinn. Wish I had medals to give him. And first prize, Dr. Gareth Mercer. Congratulations. And as a retina surgeon, you better make this work. Thank you so much. Certificates of attendance and a link to the evaluation survey will be sent via emails after the meeting and can also be accessed online. Thank you so much, everyone, for waking up this early, and nobody's asleep yet, so that's good. Have a good time in Quebec City. Enjoy.